Okay, so with the barium enema study, it's a little different than the small bowel. So the small bowel, our patient, they prepped, we did our abdomen scout, and then we took our overheads, and then the fluoro happened. But the BE, it's the more traditional approach, right? So now we've already performed our scout, we've got approval from our radiologist to proceed with the exam. Now we have tipped the patient if the protocol allows us to. At some facilities, the radiologist will tip the patient. In some cases, actually, best practice is that they at least inspect the anus, right? Like, it's important that a doctor does that to make sure it's not obstructed, but at some facilities that may not be the case, okay? So this is all done. She tipped, the bag is hanging, the radiologist has performed his fluoroscopic part. Now we've set the bag on the table to relieve the pressure from the colon, and the patient is in the AP supine position. And we're going to go through our progression of projections. We're going to begin with an AP supine abdomen. Again, we're just going to do this lengthwise for the sake of time for us, okay? So we'll do an AP supine and AP axial. Then we'll do one of the obliques. Obviously, with the procedure, you'll do both. And then we are going to be doing our decubitus followed by our lateral rectum. Now, the decubitus images are only done on double contrasted studies, but those are typically the most common, okay? So just keep that in mind. And again, familiarize yourself with the hospital's protocol. So, here we are, doing AP abdomen. It's very straightforward, right? We know how to do this. Right our crest, we're already set up. Blow your breath all the way out, hold it out, beat. Review the images, make sure that you have both flexures as well as the tip coming out. So I would honestly do 2 crosswise on this one so that I could include that balloon at the bottom. But again, I'm just showing you the procedure, okay? So then we've done that. On this, you want to be fast, right? Because they're still under a lot of pressure. The radiologist just filled their colon with barium and air. They're typically really uncomfortable. So then we're going to put our, say, we'll do 30 degrees, 35, 30 to 40 degrees. So we'll put an angle on it. We'll center the lower ASIS. Actually, so on her, if you notice, going below her ASIS is putting us way down here. That's way below the tip, right? So if we go right about at her ASIS, that's gonna give us that. Now the good news is usually there's a plastic tube pointing exactly to the bottom, okay? So it's like you know where you need to be. So you put your angle on, and you set up your cassette, okay? Notice the cassette is way higher than here, all right? So in your textbook, the IR placement is gonna say like below or like at the crest, and then the central ray, there's gonna be a discrepancy there, but that's due to this sharp angle, okay? So we've got our angle, we've aligned the cassette, we've got the pertinent anatomy. Now we are going to take the sigmoid colon on this one, and it's gonna unravel. We're gonna extend, like lay that spring or that slinky out, okay? So it's a beautiful picture, beep, that's that one. We'll come back, and now we can start performing our obliques. Again, as I told you in class, the sponges we have in here are not to be used for barium enema. If you notice, they are porous and spongy and will absorb. There's messes with BEs. You want a non-permeable membrane to cover these that can be easily cleaned off, okay, for reuse. All right, so grab your shoulder, then that leg, roll up. You're gonna position this just like you would a lumbar spine, basically. And then roll back, your arm just like that, and you're gonna poke. Now, this is the LPO position. So it is designed to demonstrate the side up. Now, I know that the hepatic flexure is lower than the splenic flexure, in addition to the fact that I paid attention on my fluoroscopic procedure. So I have a general idea of where her hepatic flexure is already located. So I oblique my patient. I'm at the crest, and then I'm a little bit, I think it's 1 to 2 inches away from the midline. Should be here and come over. Just like that. I'm not concerned with her splenic flexure, okay? All I'm really concerned with on this one is the hepatic flexure, because I can get the splenic on the next picture. Now, I would adjust my patient slightly because she's a little crooked, but again, a little bit off midline. I know it's like right there, okay? And then I'd shoot it. Obviously, if I saw that it was high as well, then I'm gonna focus on the ascending and the hepatic flexure for this projection. And then I do the same for the splenic, and the splenic should be higher. So during the competency, if you are required to perform the RPO position, keep in mind, I'm anticipating that you're going for the splenic flexure. So you are gonna be higher than the iliac crest, if that makes sense, okay? So that's what we're going for. Roll up slightly and still the sponge. So you shot one oblique, you shot the other oblique, okay? Now, the typical pattern we utilize is we wanna move them as little as possible. So we go RPO, No, let's see. How do we do this? We do AP axial. Then what do we want to do first? We want to finish up with a left lateral. So it'd be, it's 6 one way, half dozen other. They're gonna have to roll to get to it. So let's go ahead and we'll do our, since we'll do the left lateral. Go ahead and roll into a left lateral decubitus position. So I'm gonna roll my patient up on their side. And I'm gonna set everything up for the DQ. So these are some of the, you're approaching the end of the procedure. So you can imagine at this point how the patient feels, right? Typically, they're not gonna be able to roll as smooth as McKenna did, right? Because they're uncomfortable. They've been laying on this hard table for quite a while. And they've got an enema tip still inserted in their rectum. So they're uncomfortable. So at this point in the procedure, in real life, you can anticipate, when you're a new student, you can anticipate sweating, okay? And starting to feel stressed out because your patient's like, I can't hold it. And you're like, yes, you can, go team. So, anyway. So you have to have a grid for these, okay? The KVP for a barium study ends up going higher in order to penetrate. So without a grid, you're gonna get too much scatter and you're not gonna have pretty images, okay? So this cassette holder is antiquated, so give me a moment. All right. Move your arms up a little bit. You load your cassette, and you want it approximately at their crest, right? Approximately. Pull you this way. So I'm just gonna make sure she's nice and straight. She's got a sheet on the table, so I'm gonna slide her. Here's our crest, okay? Now, her right side is up, so that's her hepatic flexure. Again, I know the approximate location. If I was doing the splenic, maybe I would come higher with my cassette, but I'm ballparking right now. I'm like, okay, center there, good. Now, I'm gonna put this down in the pelvis, my right marker, since the right side is up, the bottom of my cassette. Okay, now some facilities want you to put a decube marker on there as well. Then, I'm simply going to center to my grid, put it on tabletop, forgive me. Just open it up. You're sweating, you're stressed, you're trying to be quick, right? So notice here, the shadow of my line crosses the midline of my grid right there. And I don't want light on the wall, so then I'm gonna cone in until I'm only irradiating the cassette, okay? Then, slow your breath all the way out, hold it out, beat. That's my decubitus, okay? Then I check, I got the flexure. Remember what I'm getting on this. I'm going to get the medial border of her descending colon, which is down here, right? And then the lateral border of her ascending colon on the right side is gonna be filled with air and coated in contrast and be demonstrated very well. So there's our decube. Now that we've got that one, now we know that our protocol calls for a left lateral. I'm trying not to shine light in your eyes here. So there's a lot of moving and it needs to be relatively smooth and quick. We shot both our decubes and now we're gonna load back up in the table and do a lateral rectum. So this is a left lateral, get a left marker. Some facilities are gonna shoot this on 10x12. 14 bottom. So by convention, we mark anterior and in the bottom. There will be nothing of import down there, okay? So again, we're lined up. This is good. We're gonna center approximately at our ASIS, but you do need to include the balloon. So like I told you before though, there's literally a tube pointing at where you need to be at the bottom, okay? So that's gonna be easy. Palpate, ASIS is here. That's where I'm gonna go. Mid-coronal plane is there. And then I'm just gonna look and be like, do I have the balloon or not? I do. All right, let your breath out, beep. Okay, then you tell the patient as you approach this, look, we're just gonna keep going. You don't wanna say one more picture, but you do wanna give them an idea that you're getting close so they can have some relief, especially if they're having a hard time. And then you need to be certain that you don't make a mistake at that point and extend that time period. Because if you do, then you're increasing the odds that they're not going to be able to hold that pressure in anymore, okay? So we've performed our lateral rectum, at which point you're like, all right, just relax. I need to talk to the radiologist very quickly. There'll be another tech with you most likely. Have them wait. Go talk to the rad. Say, hey, Dr. Jones, I've got all your images. Is there anything else you want, or can I go ahead and empty the colon? Just gonna scroll through real quick. Looks pretty good to me. Just go ahead and do your post-evac. Your protocol will dictate the post-evacuation film. It may be an AP, it may be your lateral rectum. But before you do that, what you have to do is you have the enema bag. The tip is still inserted, the bag is on the table. You'll have a biohazard trash can, the red with the red bag. You take the enema bag, you drop it in there, and then you open the clamp. And the barium will flow, that blue clamp, do I have it here? So there's a clamp on here. Yeah, this one, right here. So this blue clamp will be clamped down, and that's what kept the barium in there. So you'd open this blue clamp, and it's gonna flow back through the tubing into the bag that's in the biohazard can, okay? You let as much of that go back into the can. You'll watch it come down the tube. When it stops flowing, you say, okay, now you take the pressure off of the balloon that you blew up that kept the enema tip inserted in the patient, okay? Once you do that, a little more will come down the tube. When that is done flowing, you say, okay, pull the tube out, you have towels ready, you help them get cleaned up, you set them up and say, okay, now I need you to go to the restroom and try to empty your bowels as much as you can. So you walk them over and you let them do that. You make sure they're comfortable and they're safe, obviously, and that they're clean. You clean up whatever you can while they're in there. Stay nearby, check on them occasionally. Are you okay? Are you finished? Are you okay? Are you finished? Once that's completed, they say, yeah, I think I'm good to go. And they're gonna feel a lot better and be a lot more compliant. Say, okay, now we're just gonna do another image or so, all right? Always leave yourself that room. We're gonna do another image or so, and then we should be about done, okay? You ready to go? Yeah, I'm ready to go. So come back up and you position for whatever your protocol calls, lateral rectum or the AP post-evac. Make sure you mark it with the post-evacuation marker, which is here, okay, post-evac. And then show your radiologist. Now here's the thing, they may want to look again before you release the patient because some people don't empty well. And if that's the case, he may say, you know what, let's wait, have them see if they can go again later and take another post-evac. So that's kind of the process, and at that point you kind of play it by ear, but if all things go well, you did your post-evac and you were done.